Hello, my name is Kevin Farmer. I'm from the University of Florida, and I have the pleasure of speaking on in-season management of shoulder injuries. I want to focus on the things that we've learned from dealing with American football and how we handle shoulder injuries during the season as opposed to the off season. These are my disclosures, consultant fees. I do want to point to a book that I recently published. I have no royalties, but it does go into a lot of detail on the things that we're talking about managing in-season injuries. Again, I'm from the University of Florida. In the United States, college football is a large cultural phenomenon with millions of fans, and it's something that on Saturdays takes up most of our attention. And again, I want to thank you for the opportunity. So let's start with the obvious. Shoulder instability. It is very common in contact athletics, especially American football. In this study looking at the NCAA, they found 0.4 per 1,000 athlete exposures during a spring football season. This study looking at the University of Southern California over a 10-year period found 31 Bankart repairs, so about 3 per year. There's about 100 athletes per team, so that equals about a 3 to 5% rate of shoulder instabilities per season for a high-level American football team. The NFL Combine, that's where all the prospective collegiate athletes come to be evaluated to possibly be drafted into the NFL. In 2005, 336 athletes came through. 14% of them had had previous instability surgery, indicating how common of an injury this is. What's sort of the gestalt algorithm that we do when we treat these athletes in season with a first-time subluxation or dislocation? Typically, we try to return when pain is resolved. Obviously, we obtain x-rays and MRI scans to evaluate for the level of injury when making these decisions. If we do get them back to play, I typically wear a brace of some sort. We use a Sully brace, or I favor the harness, which actually attaches to the shoulder pads, and I'll show you a picture of that. If we can get through the season without having any recurrent instability events, then we typically will pair it right away in the off season to have them back for the following season. Obviously, if they redislocate or have a recurrence, that typically pushes us towards operative management, but that can be kind of variable based on where we are in the season and things like that. What is the success rate of that approach? This study looking at the military academy found that a first-time in-season dislocator, if you were to make it through the season using this approach and fix it in the off season, had a 90% success rate the following seasons of not having any recurrent events. Now, it's important not to let the success of this season change your thought process. If you decided, oh, we made it through the season, they did well, let's not fix it, that approach only has a 40% success rate. So really, if they have an instability event, they have a Bankart tear, you get through the season, you should still fix it in the off season because the recurrence rate is still very high in the following seasons. This study in the NFL over an 8-year period found a 92% were able to return to play that season after an instability event. If it was a simple subluxation, they often returned the same game. If it was a true dislocation, it took about 3 weeks typically. On average, there's about a 55% recurrence, usually around 2 to 3 weeks after the initial event. At the collegiate level, this 2-year study looking at 45 athletes found that 73% were able to return that season, about a 5-day median, 64% recurrence. 2/3 of those who had a subluxation were able to complete the season, and a subluxation, not surprisingly, was a much better outcome than a complete dislocation as far as being able to complete the season. If you wanted to look at functional scores to get an athlete back to return to play, the WOSI and simple shoulder test can be predictive of return, and time loss is most associated inversely with a simple shoulder test. So if you wanted to get an idea of how long it may take, the simple shoulder test is the best test to look at to see how involved their injury may be. Operative fixation in the off season, we're not going to get too into the woods about that, but the outcomes are variable. This meta-analysis, 26 studies, almost 800 contact athletes found that after operative repair, there's still an 18% recurrence, but if you minimize bone loss, maximize the amount of anchors, and repair in a lateral position, you can get that recurrence rate down to less than 8%. Posterior instability, also very common in these athletes, especially the offensive and defensive linemen who are constantly blocking the player in front of them. The most common complaint that I see is pain and not frank instability. And then again, very common, this study over a 6-year period of MRIs at the NFL Combine found that 38% of the athletes coming out of college going into the NFL had evidence of posterior labral tears on their MRIs. Obviously, in recurrent instability, persistent pain, surgical repair is a primary option. But if you're able to, I prefer to try to get through the season. This is a harness brace. You see in that picture, that black brace attached to the arm and then attached to the shoulder pads, tries to minimize getting your arm into those positions of maximum risk. So sometimes the glenohumeral cortisone shot, just to calm things down, can be helpful. If you look at whether or not braces help, this study found that if you wore a brace, you're able to make it back in about 9 games or practices missed, compared to almost 40 with no brace. In this study, looking at posterior instability, found that eventually almost 80% of the athletes required surgical repairs, and the biggest predictor of those who needed to have repaired were pain with bench press. So that's a question that I commonly ask these athletes. Does it hurt to bench press? Does it hurt to do push-ups? If it does, that's significantly associated with needing operative repair at some point moving forward. And obviously, outcomes following operative repair are very successful in this population, with 93% return to sport and 96% excellent outcomes. AC separation is very common. Most are type 1, average return about 10 days. This study, the NCAA, again found most were type 1 or type 2. A type 1, about 11 days lost. Type 3, up to about a month lost in time. Treatment, we all know this, rehab, anti-inflammatories, a cortisone shot done very acutely, I find very helpful. So if I get an athlete that gets a type 1 AC injury in practice, I try to inject them after practice right away to try to mitigate that inflammatory response. And I usually find that I can get them back to practice the next day after doing that. A local anesthetic is very commonly used before games. I typically prefer Neuropen or 0.75% Marcaine, as they're longer acting. And we try to do that as close to kickoff as possible, because the Marcaines last about 4 hours, and the usual game is about 4 hours. This study, looking at rugby players, found no detrimental impact from AC injections over a 10-season follow-up. 50 cases, almost 5 injections per athlete, found that most of them thought it was helpful, and 0% said they would not do it again. Only 3% felt like maybe their symptoms were worsened by the injection. So fairly good evidence that injections in this injury are accepted and don't cause any ramifications. SC injuries, again, this is something that are not as common, but certainly can be very concerning. Anterior SC injuries, we work with bracing, anti-inflammatories, modifying activities. Obviously, a posterior SC instability event in a practice or in a game is an emergent situation, taken to the hospital for closed versus open reduction. In the NFL, average return is about 4 to 6 weeks after a posterior SC dislocation. This was one that I had recently that had to do an open reduction, and I added an internal brace to it to try to maximize the strength of it to minimize the chance of recurrence. So using a suture tape placed anteriorly to reinforce after an open reduction, I find in some cases to be helpful. Clavicle fractures, also common. This study in the NFL, 17 players, 3.5 months to return. On average, they've missed about 8 games with non-operative management. Again, 97% return, but on average about 8 months to get back. If they had them fixed, in this case, this study in the NFL, 17 athletes with fixed clavicle fractures, 94% were able to return in less than 3 months. 44% were able to return in the same season. Therefore, fixing a clavicle fracture in a high-level contact athlete may speed up the return to play and may be more beneficial in that population. Pec major tear is obviously an avulsion of the tendon is repaired, but an injury of musculotendinous or partial, often we use biologics, PRP, with a return in about 6 weeks. Pec minor, this is a case report of a pec minor injury, very uncommon. able to return in a week or so with physical therapy plus minus biologics. So in conclusion, the in-season approach to American football athletes and shoulder injuries is very different than the off-season. It's important for patients, athletes, coaches, athletic trainers, and physicians to understand the risks and the benefits and the risks of waiting to try to get through the season. So again, thank you very much. I really appreciate this opportunity. It's a pleasure to be involved in this great conference. I look forward to our live discussion later tonight.